So good evening, everyone. This would be the 88th edition of the Insta lecture, and it would be on focal segmental glomerulosclerosis. Because currently I'm doing a series on the lectures on the glomerular disorders, and this episode would be on FSGS, focal segmental glomerulosclerosis. Now, FSGS comprises 20 to 30% cases of all nephrotic syndrome globally. And it's a very common cause of nephrotic syndrome in the adults and a very well-known cause in the children. And we try to understand that what are the causes, what is the meaning of the term FSGS, when we call a condition FSGS, who gets affected by this, and how to diagnose, what are the key diagnostic feature, and how to differentiate it from other causes of the nephrotic syndrome. This will be the key learning objectives in this session. So I do it by a short PowerPoint presentation, and I would like to show you the PowerPoint presentation right now in a moment. So anyway, focal segmental glomerulosclerosis, basically the term means that, so let's start with the presentation. So focal segmental glomerulosclerosis, there are two key words here, which focal and segmental. And from the name, you understand that this is a glomerular disorder, and what is the pathology seen in the glomeruli? That is sclerosis or scar formation. But we need to understand the key meaning of the term focal and segmental, which I'm going to deliver on the next few slides. So these are the learning objectives which I already mentioned. So the term FSGS is characterized by sclerosis, the scar formation of some but not all glomeruli, which involves a part or segment of each glomeruli. Now, in the context of the renal pathology, the term focal and segmental have a specific meaning, and that you need to understand. The term focal means that if I look at a kidney biopsy and less than 50% glomeruli are involved by that pathology, then only you use the term focal. If more than 50% glomeruli are involved by pathology, you use the term diffuse. Similarly, the term segmental has a specific meaning. In those glomeruli which are showing the pathology, if less than 50% segment and portion of the glomeruli is showing that pathology, use the term segmental. If more than 50% area of the glomeruli is showing the pathology, we use the term global. So it's a very important point to understand the full meaning of the term focal, diffuse, segmental, and global. This is very important. So here the term is used focal and segmental. So literally it means that less than 50% of the glomeruli and the kidney biopsy are showing that pathology, there is a scar formation. And segmental means out of those glomeruli which are showing that pathology, only a segment, less than 50% portion is showing that pathology. This is the key meaning of the term focal segmental glomerulosclerosis. So the key concept here is this, that the terms focal, diffuse, segmental, and global, they have a specific meaning in the context of glomerular pathology and in the context of the renal pathology, that you need to understand the meaning of the term focal segmental glomerulosclerosis. As I mentioned, this is one of the major causes of nephrotic syndrome in the world, comprising 20 to 30% of all cases of the nephrotic syndrome. Other causes of nephrotic syndrome are membranous nephropathy in the adults, minimal change disease in the children. IgA nephropathy can also cause nephrotic syndrome. Membranoproliferative glomerulonephritis, MPGN, can cause nephrotic syndrome, and secondarily nephrotic syndrome could be caused by diabetes mellitus, amyloidosis, SLE, and drugs, and many other causes. So FSGS is basically, it's thought to be as a recognizable pattern of kidney injury which is appreciated on the kidney biopsy. And what is that uniqueness of this histologic lesion? That the sclerosis or fibrotic lesions would be appreciated focally, involving less than 50% of the glomeruli, and segmentally in those glomeruli which are showing the pathology, less than 50% of those glomerular tuft would be affected. This is the key meaning of the term FSGS. Now, obviously, to initiate the pathogenesis of this disease, the key is the injury to the podocyte. It's basically a podocytopathy, just like the minimal change disease. Now, let's understand the basics that this is to normal glomerulus to understand the compare and contrast that what is basically happening in the focal segmental glomerulosclerosis. So we know that glomerulus is nothing but a seawater filter. It's a basic filtering unit of the kidney. Like in our home, we have water filter water purifier, and that contain a lot of filters. Similarly, in our body, to purify our blood, to detoxify our blood, actually, there is kidney, and in the kidney, the key filtering portion is its glomerulus. So it's just nothing like a sieve. And what is happening through this, the blood from the whole of the body is going through this capillary duct, and they are getting, and the primary urine is basically produced, which is going through, the filtrate is produced, and that goes to the tubule. Some amount of absorption, reabsorption occurs, excretion occurs, and that results in the production of the final urine. So it's basically nothing like a sieve, like the way we produce teas in the roadside tea stall, that glomerulus acts like basically like a filter or sieve, just like the sieve which we use at our home. And you can think that this is the glomerular filter. And so this is the key idea, that if you want to understand glomerulus disorders, glomerulus is a filter, and you need to understand the glomerular filtration barrier, because it's the basic filtering unit of the kidney. These things I already mentioned, and these are some basics which you can go through at your leisure. Now, this is glomerulus, and this is glomerulus because glomerulus is nothing but a bunch of capillary duct. And what we see here, that this glomerulus, if you look at under the electron microscope, this glomerulus, the glomerular filtration barrier, is made with capillary loops, endothelial barrier, followed by the basement membrane, and over the top of the basement membrane, there are the podocyte of the food processes. And these three things, actually, this endothelial barrier, then the basement membrane, and the podocyte of the food processes, junctions, these comprises the filter of the glomerular filtration barrier. And particularly, this disease, the FSGS, is basically a damage to the podocytes, which usually results in the proteinuria. Injury to the podocytes is the initiating process. Now, FSGS may be primary, may be secondary. These are the causes of the secondary important one. HIV infection could be due to CMV. It could be due to parvovirus B19. There could be heroin abuse, some other drugs also, and could be secondary to other forms of glomerulonephritis like IgA nephropathy. Now, it's a very common lesion among the adults who are presenting with idiopathic nephrotic syndrome. And those countries where there is a detailed study done on this glomerular disorder, they have found that this is the most common primary glomerular disease seen among the patients who are having end-stage renal disease. Particularly, the study is done in US. And pathogenesis, as I mentioned, that injury to podocytes of the visceral epithelial cells are thought to be the initiating event. And some people, experts, think that FSGS is basically a severe form of minimal chain disease, that they are in the same spectrum of the disease and the podocytopathy. And basically, the disease process is a podocytopathy, which is initiated by the damage to the podocytes in the glomerular filtration barrier. And a circulating permeability increasing factor produced by lymphocytes is suspected, which usually results into the damage to the podocytes. Why this has been thought, that it has been seen that even after doing kidney transplantation, rapidly this thing recurs. So that is the idea, that something is there in your blood, actually. There is some increasing permeability increasing factor which is produced due to some immunogenic reasons, which is damaging to the podocytes. Classification, there are three key types: primary, secondary, and some genetic causes. There could be familial types also. Why this classification is important? Because the management and therapeutic purposes, they're treated differently, basic from particularly the primary ones. Now, primary FSGS are usually treated with immunosuppressive medications, compared to that secondary, they're usually treated with treatment of the underlying of the root cause. Secondary FSGS, as I mentioned, could be various reasons. So you need to look into the exact cause which is leading to the development of the secondary FSGS. It could be due to drugs and toxin, as I mentioned. Heroin abuse is a common one, interferon, pamidrone, and viral infections, particularly HIV-associated nephropathies usually is a prime example of secondary FSGS. It could be due to parvovirus B19, it could be cytomegalovirus, sickle cell anemia, glucose 6-phosphatidylserine deficiency could also associated, glycogen storage disorders are also associated, and it could be due to reduced nephron mass also. Now, what exactly leads to the development of the secondary FSGS? Its mechanism is a little bit different. It's also due to some injury to the podocytes, but its mechanism, its process is a little bit different. The key idea is here is this, that podocytes are unable to replicate. So after some kind of injury by toxin or drugs, the podocytes which are there, they cannot replicate. And as a result, there is a decreased podocyte density occurs in the glomerular filtration barrier. And focal areas are denuded of the podocyte food process from the glomerular basement membrane. And this decreased density of the podocytes will lead to the secondary FSGS. That's the key idea. Clinical presentation of FSGS, patients with primary FSGS, mostly present with acute onset nephrotic syndrome. As I mentioned, 20 to 30% cases of nephrotic syndrome are usually due to primary FSGS. Secondary FSGS, there's a little bit different variation, is that they are usually more of chronic onset, insidious onset, and slowly increasing proteinuria is noted. In case of childhood onset genetic disorder associated FSGS, usually see childhood onset FSGS. They can have autosomal recessive mutation, can have also a dominant also, and patients usually present with progressive or severe nephrotic syndrome. So in a nutshell, FSGS typically presents with nephrotic syndrome, the key prime cause of nephrotic syndrome. There's a Columbia group classification is also there. You just need to know in brief, and they have usually classified the specific histologic findings in the FSGS, and they are divided into deep lesion, cellular, collapsing, perihilar, and not otherwise specified. Particularly, collapsing variant is important, particularly in the context of the HIV-associated nephropathy. Now, come to the morphological feature. This is important. Podocyte injury is the earliest morphological injury is seen, because definitely it's a podocytopathy, and ultimately the process initiates from the podocyte injury. Glomerular disorders, as we all know, that their diagnosis is usually a three-step approach: light microscope evaluation, immunofluorescence, and electron microscopy. Light microscope, you can see increased mesenchymal matrix, you can see deposition of hyaline or hyalinosis, they say foamy macrophages, and there could be obliteration of the capillary lumina. In the second step, that is in immunofluorescence, there could be non-specific deposition of the immunoglobulins, and deposits could be seen. And electron microscope, you can see effacement of the food process, just like minimal chain disease. Now, this is a key area, that how to differentiate from other causes of nephrotic syndrome. So there are three key causes of nephrotic syndrome. One is minimal chain disease, another is FSGS, and third is membranous nephropathy. Now, to differentiate from minimal chain disease, the idea is this: that minimal chain disease usually presents with selective proteinuria. That means only the low molecular weight albumin proteins, they usually get leaked, and they are usually responsive to corticosteroid. Compared to that, in this condition, in FSGS, usually not associated. Usually, you get non-selective proteinuria, and they are not very much responsive to the corticosteroid. Compare and contrast. If I contrast it with membranous nephropathy. Membranous nephropathy usually a totally different morphologic feature. They have diffuse capillary thickening, spike and dome appearance, spikes appreciated on silver stain. They can have distinctive subepithelial deposits, which are characterized feature on the electron microscope. So this thing would be seen in the membranous nephropathy. So these are the all key concepts that you need to know about FSGS in a nutshell. Thank you very much. I'll continue the discussion on other topics.